Alright, so welcome back to MedReader. Today I have a very interesting topic that is discussed multiple times on the wards. If you're working as a resident or a hospitalist, dealing with heart failure patient these days is so common that you are going to encounter this sometime in your practice. So, cardiorenal syndrome, the bidirectional crisis, a modern clinical playbook for residents. Let's dive into it. So, the clinical dilemma, the ward scenario, and the formal definition when we're talking about the cardiorenal syndrome. An incoming admission patient is admitted for acute decompensated heart failure, receiving IV diuretics. Congestion persists, but the creatinine is spiking. Do you push more fluid or double the Lasix? Where are you in terms of treatment of such patient population? So, the formal definition: worsening kidney function during the treatment of acute decompensated heart failure is characterized by persistent congestion or diuretic resistance. So, cardiorenal syndrome, you always have to think about it as a dysfunction of the heart and kidney, which is mutually deteriorating through hemodynamic, neurohormonal, and inflammatory crosstalk. So, whenever you think about the cardiorenal syndrome, yes, congestion is the prime pathology, but there are several other factors that is continuing this vicious cycle, which includes neurohormones and inflammatory crosstalk, which is not making your patients better. And that is why it's so important to remember this. It's also tested on the ABI boards, by the way. So, when I'm categorizing the crisis, the prime movements in acuity. Type 1, what are different types of cardiorenal syndrome? You have type 1, which is your classic, approximately 40% with acute decongested heart failure comes with this type of problem. So it's the core problems in the heart, the congestion and the decrease in the forward flow affecting the kidney. You have acute cardiac dysfunction that is causing a worsening of AKI. Then you have type 2, which is chronic cardiorenal. In this patient population, they will have all chronic heart failure signs, nothing in terms of acute exacerbation, and now they're having progressive CKD that is not explained by other causes. Now, you may have certain diabetes type 2 population, or general increase in ASCVD. You might have a difficulty in understanding which pathology is contributing to their chronic kidney disease. But if you're dealing with heart failure patients and they have had chronic heart failure for a long time, you should also consider this type. Although it's very rare, and as I said, it's not well documented because you have other confounding factors that can affect the kidneys in these patients. Type 3 is acute renal cardiac. So it's an opposite. You have an AKI from any other cause, and now that's causing more venous congestion because of less filtration of the urine, and you accumulate more, not just the fluids, but also the downstream electrolytes. So contrast nephropathy, that's gonna trigger flash pulmonary edema. Although these days, contrast associated AKI is really very rare, but it's used as an example here. But it can be any cause. You can have sepsis, you can have any types of, perfusion issues, which can lead to worsening of the heart failure. But remember, type 3, when you're talking about acute renal cardiac, it starts from kidney injury and then it causes worsening of heart failure. Type 4 is similarly chronic renal cardiac patients, with CKD, just has progression of heart failure. And type 5 is secondary, systemic, both, sepsis, amyloidosis, SLE, all those things can affect the heart downstream. So the pathophysiology has a little bit of a paradigm shift. So when you think of cardiorenal syndrome, you might tend to think that you have a decrease in the cardiac output and the cardiac index from that acute decompensated heart failure, and because of that forward flow issue, you have decreased renal perfusion. But that's not the case. The most significant factor to contribute towards cardiorenal syndrome has been shifted in terms of pathophysiology to venous congestion. Now it's considered as the most dominant driver. Think about it. You have increased filling pressures in the right ventricle and the right atrium. The downstream intravascular congestion is going to transfer to the renal vessels, and you have renal congestion. You have stretch on the kidney capsules, and you have decrease in the filtration. So that's going to be, coming out as a decrease in the GFR and rise in creatinine. Especially remember, if it's an acute kidney injury, your creatinine rise is going to be higher in proportion to the rise in GFR. So, venous congestion, the most dominant driver, arterial underfilling, the classic mechanism, and also the neurohormonal and inflammatory crosstalk. This neurohormonal just means that your RAS system is more active because of the congestion. They cannot receive the blood flow to the kidneys in terms of arterial blood flow just because they're so congested, and that's gonna increase the RAS, the aldosterone, the sodium retention, and that chronic loop. So elevated CVP, not low cardiac output, is the strongest hemodynamic predictor of a worsening renal function and the evolution of cardiorenal syndrome. So the pillar one, why the congested kidney fails: intense sodium retention is going to happen before the GFR drops appreciably because of that congested state and the RAS activation. Similar incidents in HFrEF and HFpEF, undermining the pure forward failure hypothesis that we just discussed. And really, as I mentioned, compression because of the congestion is going to drop the GFR. Right-sided heart failure converts to tricuspid regurg, converts to hepatic and renal congestion. And that's how this loop is, started in the first place. Now, patients with good and healthy kidneys might be able to, counter this in a lot of ways, but for patients who have some underlying kidney damage, they're going to slip into more severe cardiorenal if not addressed. So the pillars 2 and 3, when does the compensation becomes destructive? Inflammation and endothelium is a huge driving factor, which is induced by the venous congestion. It's going to release a lot of pro-inflammatory cytokines like TNF-alpha and IL-6, specifically in cardiorenal case, which is going to do more of the inflammation and endothelium damage. The sympathetic nervous system and the RAS activation, as we discussed, just because of the congestion, your GFR drops, your RAS is active, and also the sympathetic tone is active to vasoconstrict. Your kidney and the liver's lymphatic drainage, because of this congestion, is also going to get affected. It just adds more to the congestion over time. Severe congestion plus low cardiac output, it overwhelms the filtration fracture, and the GFR is going to drop precipitously. So that's the three pillars of the pathophysiology that is mainly centered around cardiorenal syndrome. The diagnosis: urine sediments and trending. We're going to discuss more about this in the next slide. A bland sediment strongly is going to favor cardiorenal syndrome. If you have certain casts like muddy brown cast suggesting acute tubular necrosis, you might want to look into some other causes except for just this one. You need to review longitudinal GFR trends in order to see how the patient improves if you escalate the diuretics, or if it improves at all. If it doesn't improve, then you might be dealing with some other pathology that you need to address. Some of the echocardiographic markers: this is a TTE. It can be a complete study or it can be a focused study of the right-sided pressures. Your IVC diameter more than 2.1 with less than 50% collapse. It is going to suggest to you that you have right atrial pressure of approximately 15 millimeter mercury. to E prime ratio, which is essentially the diastolic filling capacity. More than 15 is going to correlate strongly that you have elevated PCWP, at least more than 18. Again, all the indicators that the right side is failing and you have venous congestion. These days you have also VEXA scanning system in terms of assessing volume status in the patient, but that's something we can keep it for the future slides or lectures. Hemodynamic profiling, wet, dry, warm, cold, which type of phase they are in. Clinical profiles always guide initial diuretic and vasoactive therapy. Invasive PA catheters can also be used, but they're reserved for refractory cases to target the exact central venous pressure and PCWP for challenging patients who might be, requiring some circulatory support and transfer to the ICU. So the biomarker utility and the timeline of injury. Now this is a little bit miscellaneous. I didn't know about this until I researched about it, that you do have some early structural markers in ours. We barely or rarely test for this in real life, but NGAL is a marker, chemical marker, that is going to rise hours before the creatinine is gonna rise. So it can be a nice supplement to encourage you to believe that this is more cardiorenal etiology rather than anything else. KIM1 distinguishes structural from the functional AKI, is helpful, and also TIM2 and IGF-BP7, some of the miscellaneous markers that you can check. But in real life, what you're going to do is you're going to track the creatinine trend and the GFR trend longitudinally from the day of admission to how they're progressing with escalation of diuretic therapy. It is insensitive to early injury though, and it is a highly delayed marker, so you need to be careful with that. One of the diagnostic gatekeeper is the BNP and the NT-proBNP. A normal natriuretic peptide level, in this case in a patient with AKI, is going to strongly suggest a cause other than cardiorenal syndrome type 1. Rethink diagnosis, especially if you have such patients. Negative BNP or not a sufficient jump in BNP when you're dealing with CRS patients as a probable diagnosis. In those cases, it might not be CRS, so think about something else. So it's a gatekeeping lab in that perspective. So what's the management? Step 1, aggressive decongestion. So you can start with spot urine sodium less than 2 hours post diuretic use. You check if that spot sodium is less than 50 to 70. If yes, then the patients have diuretic resistance. Because if you're using diuretics, they should lose some degree of sodium. It means that you might need a sequential nephron blockade if this does not happen. Now this has been discussed in the ADVOR trial. Adding acetazolamide or adding a thiazide like a metolazone booster, anything can be used to push that fluid out of the patient, obviously while you check all the electrolytes of those patients at either several hourly or daily basis. Always consider avoiding reflex IV fluid bolusing or high rate continuous administration if someone has a rising creatinine. So one thing you need to stay away from, and especially in acute decongested heart failure, is not giving them higher than required volume, just thinking that the kidneys are not perfusing. So that's why it's important to understand that cardiorenal syndrome pathophysiology has shifted to congestion being the culprit rather than the forward flow. So a rising creatinine is congestion issue. If you're dealing with cardiorenal, and giving fluid is not the answer. Aggressive diuresis is the answer. Loop diuretics, in this case, is the first line. You can use Lasix, you can use Bumix, you can use Lasix drip infusion if the patient is in the ICU with frequent BMP checks for electrolytes. You can use a form of bolus and then continuous you can fine tune your practice, but the goal is correction of the decongestion. All right, so step 2 and 3, forward flow and mechanical removal. This is just going over the stuff that we discussed. Inotropes have an increased risk of arrhythmia. You can use it in cold, wet, dry, and hypoperfused patients, but they need to be in appropriate ICU setting for that. You can use vasodilators to reduce the preload and afterload, like nitroglycerin or nitroprusside, in that circumstance. If you have a refractory shock, mechanical circulator support, this is like escalation of care. You need either like an Impella or ECMO. These are the sickest patient who don't respond to the affected cardiorenal syndrome. So remember, vasodilators, inotropes, and mechanical support is kind of like escalation of therapy if your IV diuretics fail to relieve the congestion. Always have a nephrologist on board in such cases to get a complete care in terms of your when you're dealing with cardiorenal syndrome. Several protocols and considerations in terms of mechanical fluid removal. It's reserved strictly for patients failing a stepped diuretic algorithm per the CARRESS-HF trial. Ultrafiltration was not superior. They're talking about dialysis, not superior to stepped pharmacotherapy, and has caused a great creatinine rise threshold. If your creatinine is more than 2.5 milligram per deciliter, pivot to CRRT. Peritoneal dialysis is often better tolerated hemodynamically, but obviously all these steps for more sicker patients, the first thing you should be addressing is decongesting with IV fluids and escalating. So SGLT2 inhibitors and Finerenone, which is a nonsteroidal MRA, has picked up a lot in a lot of recent studies that were done. SGLT2 inhibitors, they reduce preload by osmotic diuresis and natriuresis. It's gonna just give you an added boost in terms of diuresing the patient. It lowers the intraglomerular pressure via afferent constriction. The initial EGFR dip is hemodynamic and not protective, and do not discontinue just because there is some degree of GFR dip when you're starting these medicines. Obviously, you're going to start SGLT2 when the patient is more stable and you have done your acute diuresing. Only after that, you're going to consider starting them on this with more clinic follow-ups. Similar to that, talking about Finerenone, if it's actually FDA approved now for CKD with type 2 diabetes and HFpEF. It has kind of like shown better results as compared to the spironolactone, just because of its powerful antifibrotic properties in both cardiac and the renal tissues. So the combination of these two, as you can see in the center, has reduced all-cause mortality in MACE despite higher hyperkalemia risk, which comes also with traditional steroidal MRA like spironolactone versus just using SGLT2 alone. So combined use has additive protection. So two drugs to remember, SGLT2 and Finerenone, to prevent further repeat hospitalizations with cardiorenal syndrome. So this slide is just going over some of the things we discussed before: hemodynamic and reversible, true worsening, hidden danger, and ideal response. So treat the patient and their volume status, not the creatinine in isolation, is the key word you need to remember here. The overlap: more than 60% of all patients admitted with ADHF have an underlying CKD. Acute risk, acute CRS type 1 and 3 carry the highest short mortality risk, hazard ratio of 3.13 compared with CKD without CRS. So CRS definitely adds more to the mortality in patients, and that's why it's important to treat it and prevent it. Chronic risk and progression: type 4 CRS has relatively better baseline survival than the other types. So The residence ward checklist for CRS: stop focusing only on the forward flow. Venous congestion is the main dominant driver, along with neurohormonal sympathetic response. You measure the spot urine sodium early. This is to detect diuretic resistance. Use it within 2 hours of loop diuresis starting to see if the sodium levels are less than 50. If they are, you need to trigger the sequential nephron blockade either with acetazolamide or adding a thiazide. Do not knee-jerk to IV fluids for a rising creatinine in acute decompensated heart failure patients. You need to assess for congestion. If they're congested, pushing that fluid out is the answer. Don't be afraid of putting them on Lasix drip thinking that their cardiac output is going to decrease. You need to relieve that congestion. Normal BNP, stop, reevaluate the diagnosis, because that is pretty rare for a cardiorenal syndrome patients to not have an escalating levels of BNP, which is going to be, mutually coexistent. So that's pretty much it for today's lecture. I hope you enjoyed it, and come back for more videos on this website. Take care.